Welcome to the feeding pod. Okay, we have a clinician practicing at the top of her license in the NICU, doing meaningful research. She is a renowned speaker, Dr. Luisa Ferrara Gonzalez. We are so excited to have you. I can't wait to talk. And I don't know if you want to introduce yourself a little bit and give us a little bit of background before we dive in.
Great. Thank you, girls. I am so excited to be here. You are both doing a great job with this podcast. I didn't even know it was around because I don't do a lot of social media. So, Tova, after we had spoken a little bit, I went and listened, and you guys are doing a great job. I love that it's not just like purely like skill and knowledge and clinical, but like you're encompassing so many broader topics. And I think it's really well done. So, thank you so much for inviting me. So, everybody, yes, I'm Dr. Luisa Ferrara Gonzalez. I am a New York State licensed speech language pathologist with over 15 years of clinical experience working with infants and children with pediatric feeding disorders. I started my career off in a level 3 NICU with an outpatient feeding clinic where I started the programs and grew them, then, kind of pulled the research and went to leadership and said, hey, this is what our babies need. This is what our families need. So kind of blood, sweat, and tears go into those programs, but it's been really rewarding. And then I was managing that program for several years and then stepped into just a research role, which was also really, really, really great. I think our field is so young and it's really in its infancy. So more of us, I think, need to not be so scared of research. Clinical research is something that we are all kind of already doing. We're just not gathering and doing the stats and publishing it. So if I can help support any of you, please, the babies need the evidence to the practice. So if I can help with that, or maybe that's something we can chat about at some point today. And then I stepped into academia for a little bit, but I like to focus on babies, not big college babies instead. I did a little time in industry, which was really a great learning experience, but it did pull me too far away from the bedside. So I'm excited now, still focusing on neonates and families and family-centered care and interprofessional practice, and just started actually a multi-state private practice, kind of supporting those families just leaving the hospitals. Because as we know, they go from 24/7 support with highly specialized, highly credentialed therapists and staff, and then they go home. And like the pediatricians aren't really equipped to discuss and to really give them that level of care that they need for, especially for feeding practices. And then if they're getting EI, sometimes those therapists don't know enough about neurodevelopmental care and the real trauma of being in a NICU and what their neuroprotection strategies might look like. So we're trying to fill that gap, and it's been really, really hard. There is a steep learning curve, but it's been fun and it's very new. So we can fall and fail at any moment, but for right now, we're giving it our go. So,
Oh, I
uh,
love that. And I know that Tove and I can both speak to the transition to home and kind of what that can look like with some providers. I want to really quick before we jump into some of the outline we have. I love what you mentioned about like so many clinicians, like you're kind of already doing research. We may not be like fully tracking the data, right? But we're constantly taking data with the patients that we see. And that is something Tove and I have talked about all the time where I'm like, Tove, start taking data on that. Like start marking it down. Let's
yeah.
start accumulating information on this. So I would love to, chat more about that and we can, bridge that conversation later. But I think that that's a huge one where clinicians can actually get a lot more involved in it than they think. And I know especially like implementation science. I'm going on like a totally rant now, but like implementation science is so important for researchers to partner with clinicians that have like their feet on the ground, and it's so important for that. So that's okay. Side note, Tova, we're gonna do an episode on that.
Yeah, okay. And oh, sorry, what were we going to say?
No, I was just going to say it's so important, and I think that the type of research that we need to do, we're moving away from like standard science. Like it's really hard to do randomized control trials because we know that these services are good. Like how can you go to a family and say, well, we know this therapy is going to work, but we're going to like structure it and see if it doesn't work so great for your cohort versus like you can't do RTCs in our population because there's just too much risk in that critical period. So really, like we just need data and like we're collecting it. So it's really not as scary as it could be.
Yeah.
Yeah.
And we can totally talk about research today. So, we wanted to talk about something that you mentioned, challenges that face families with that discharge from NICU to home, and then also talk about challenges that we as clinicians face on both sides of that transition. And then we can get into like ways to support these
Yeah.
families and thinking about also not just one-on-one with families, but also getting into a little bit of like that big A advocacy where we think about what you had mentioned also, how can we change this on a process level, on an administrative level? And I think that can be also the same way as research. It can be intimidating for us to think about that stuff, but a lot of it, when we break it down, it can be really, there are simple ways that we can do that.
Yeah.
So,
Yeah. No, I was going to say, I think the biggest key is knowledge is power, and someone's got to start. So, like, if you want to really change, if you really want to be an advocate for change, I feel like you got to gather all of the evidence, and it's out there. Like, let's just say, like, you like how does it maybe a NICU professional help with that transition to home, right? Well, we have to start working on better follow up clinics that are highly accessible, follow up clinics that aren't scheduled 3 months post discharge, but really
mhm,
support the families right away. And how do we get staffing for that? How do we bill for that? There are really great research studies out there. A really great program has been set up by Brigham Women's in Boston, and they did a great presentation. If you guys have ever seen their seminar, their workshop they hold every year, it's usually in September. It's headed by Dr. Pamela Dodrill. They talk about this follow up program. It's spectacular. And so I would recommend you take it. You get all of that evidence and then you bring it to leadership and you say, let me help you with this. I don't think they realize that therapists are so passionate and so dedicated to the cause and are interested in advocacy and in change and in improvements. I think they just think that we're there to like, I don't know, just be developmental specialists, but like we are more. We really are as part of the team. We are
mhm.
more. So I believe that if you gather it and you share it and say, I want to be a part of this, I want to lead this, a lot of times you'll be surprised. They're like, oh, okay. And then they help you, right? So you just have to make that first step
Yeah.
oftentimes.
I love that because I think it's very much looking at that big picture, that like capital A advocacy, right? Like we are advocating for families on that individual level all the time, right? Like we should be doing that in our practice very regularly. But when we think about it broader scale, and I think too, sometimes we forget, like, wait a minute, like if we take the time to implement something on this bigger scale, we're actually making it easier for everyone involved,
Yeah.
right? Like we're making it easier for the families to get the care that they need, the patients to get the care they need, and for therapists to do what they want to do. Like, right? Like to provide that care and treatment. So I think, but I literally wrote down the quote when you said it. You said knowledge is power and someone's got to start. I'm like, I love that because it's true. It's like if you're listening to this and you're like, I've been thinking about this for a while, it's like just gather the knowledge and start. It just you have to just go.
And not that it's easy, and it certainly is time
Yeah.
consuming, but we complain sometimes and we complain and we complain and we complain. And if you really want better care for these infants and their families, sometimes you just got to take one for the team and do it. So,
Oh, yeah. My dad always said this quote growing up, and I feel like it fits into this conversation. He always would say, like, we were talking about something, and I'm like, that's going to be hard, or, whatever. He would always say, it is simple, but it's not easy. Like,
mhm,
I recognize that that is hard. It's a very simple, like, equation of what we have to do, right? Like, we know we have to, like, just build the steps, bring it to administration, go. That doesn't mean it's easy. But I feel like that's what like a lot of these advocacy things. It's like it's very simple, but it's not easy. It is something really hard to take on.
absolutely. And this whole idea also aligns with the research because, again, I don't think the rest of the medical team realizes that we could be a great ally for data collection and publications. So, a lot of like if you're in a teaching institution or if you have a fellowship program, they are required to do research. So if you bring this idea to either the fellows or to the newer doctors that are hired, because it's like built into their contracts, and you say, "Hi, I have a really great idea. Would you like to do this with me?" Like that, my CPAP study that I did with a pulmonary fellow, and like she helped me with so much of it. Like it was like I was really really new to research at the time, right? So So definitely reach out to other people, that leadership, the other people that may not consider you like so crucial to the team, but you are. Like, we really are crucial to the team. And I think they have to start recognizing that. And we do that by opening our mouths and telling them all the great ideas we have and showing them how passionate we are about the babies and their families. So,
And so we're talking about those big A solutions. And so now if we like step back and rewind backward chain with us to
reverse engineer,
what's that? Reverse engineer.
reverse engineer it.
Yeah. So Dr. Louise, if you could talk about to get to this point, you had to recognize that there were challenges facing these families at discharge and clinicians. So if you can get into what you were noticing and what you commonly see now too.
Yeah. I think that when we first started in the field, there was less ongoing communication with our families. And there was this really big, like, hooray, they went home. Like, our job is done. They're perfect now. It's great. But I personally started seeing this difference when nurses were like, oh, I'm friends with this family on Facebook and they're saying that they're still struggling with this. Or, oh, I just, we met up with this family, or we were doing like a NICU grad day and they're all complaining about X, Y, or Z. Or, oh, we went to the follow up clinic and now they're reporting all of these feeding difficulties, right? Like, so I think there's just a lot more communication with our families post discharge. So I think the NICUs are now becoming a lot more aware. In terms of the difficulties we're having, Dr. Britt Pados just did a really great systematic review, finding that it was like 40, either 42 or 49, 42% of the babies that go home continue having feeding difficulties until 4 years of age. That's a lot
Oh,
of babies, 42%. So I think it's really important that our neonatal staff as a team knows that, because it kind of takes the hooray out of it. And it really puts the pressure on, let's not just make sure we get these babies home. Like, years ago, the goal was save them, grow them, get them home. And this was great. Everyone was super happy with these. But it's really save them, grow them, get them home with the least amount of morbidity. That is where we thrive in preventative care and in habilitative medicine and in a team interprofessional approach and family-centered care and neurodevelopmental, like all of these fall into get them home, but with the least amount of morbidity. And so knowing that they're going home with a lot of morbidity, and some of the morbidities are really subtle. Like, I think, especially the neonatal nurses, when they think of morbidity, they jump to really big players. They think of like, oh, early oxygen use and ROP and blindness, or early, too much handling and intraventricular hemorrhages, and then later cerebral palsy. Like, they jump to these big players. But what's actually happening is our NICU grads aren't going home with a lot of those big players anymore. They're going home with a lot of these more subtle diagnoses that really do affect their quality of life, like anxiety, depression, OCD, ADHD, sensory integration dysfunction, lower IQ. So we're doing a great job setting them up with early intervention, right? They're getting their speech, their OT, and their PT right out of the NICU. But some of those other morbidities, they don't sneak up until closer to school age, and they may not be in the system then. Maybe we've fixed their plagiocephaly and their torticollis and their early feeding difficulties and their toaster head, right? We fixed all of those things, but these other almost more cerebral diagnoses, these morbidities, are the ones that are really affecting them. Do you know NICU babies have higher rates of suicide in adolescence than full-term babies? Things that
wow.
truly affect their quality of life and the family's lives. So these kiddos are going home with a lot, and the families are feeling like there's the trauma of not having their pregnancy and their birthing experience and their early months as mommies and daddies and caregivers not being what they had originally expected that to be. And then they become so laser focused on getting home that when they're then home, we see a huge increase in parental depression, because they are no longer within that support system and they feel alone and they have nowhere to go, and their pediatricians can't always support them, and some of them can for sure, but for the most part it's a whole different world when they're out and released back to the community. I will also say I trying to get a better understanding of these parents' needs for fun on my spare time, I joined a bunch of NICU parent Facebook groups, and I tallied up over 4 days how many questions parents asked and how many of those questions were feeding related. And it was like 82%. Like they have nowhere to go, that they're going to social media for feeding questions. Like we're doing something wrong if they have to go and post it on Facebook about nipple flow rates and what position to hold your baby and I burp the right way, and we've got to do better, right? We've got to let them know that there's a way to help. So I feel like I'm ranting, but the
No,
NICU
you're
therapist,
not.
yeah, the NICU therapist, I think we're doing a great job advocating on that case by case kind of scenario. But again, like you keep saying the big A, and I love that so much. Like I think there's a lot more that we could be doing in terms of really advocating for better follow-up systems for these families.
And the little A side, what do you think are some of the barriers that we're facing that are leading to these gaps in care? Because there are outpatient clinics, there's EI, there are like resources
Yeah,
out there. So where do you think
yeah.
the breakdown happens?
No, I think it's great. So I think that when you're an outpatient pediatric feeding disorder SLP or practitioner or therapist or clinician or whatever you want to term yourself, I think that there's just a night and day difference between a infant with feeding difficulties, a toddler with feeding difficulties, and an older child with feeding difficulties. And then you have like the other buckets, right? So you have like the buckets by age, and then you have the buckets by the difficulty, right? So it's, it could be just motor, it could be sensory, it could be psychological, it could be family. There's so many buckets there. And I think that if you really want to support the neonates as they're coming out of the NICU, you have to get a very, very rich understanding of what prematurity actually means. I gave a lecture once about like really understanding it, because when I was an outpatient before I really was in the NICU a lot, like it was just something I put in their history, like a history of prematurity, and like I never thought about it. Like it was just it's right in there with like asthma and GERD. Like it was just boom, 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 boom. And I don't think I really understood like the pathophysiology of what prematurity does for their brains and their trajectories and their family bonding and their whole futures. So I think you have to just get a really, really solid understanding of that. I will also say, getting certified as a certified neonatal therapist, there are avenues if you're not just in the NICU, like you can still get mentorship in the NICU. And honestly, studying for that exam alone to become a CNT was so, so beneficial for me in my practice, because we do get stuck in silos in outpatient. I'm an SLP, you're an OT, you're a PT. We can talk once a month, we could work on, but it's not really interprofessional care. But I love how neonatal therapy has really pushed through and has recognized that for these babies, SLPs, OTs, and PTs, we really, really work similarly. We work towards the same goals. We share responsibilities. And when you're then studying to become a certified neonatal therapist, you're just getting a better understanding of how to do that and learning things that you wouldn't normally learn as an SLP. So I would guess recommend, like on the smaller side of it all, if you really wanted to support, I would just get a really solid understanding of neurodevelopmental care, neuroprotective strategies, dip into the OT and PT literature for neonate, and then just really understand embryology. I mean, I'm a embryology geek, love it, but it's amazing that there's so many of us that are normal walking around.
It is.
Like,
I've heard you speak on it too, and you break it down in a way that makes it so easy to understand. So
yes.
we can have you come back and talk about embryology one day because
I
it's
could talk about any of it. I love this so much. But it matters understanding when and why and what they're missing and what normal looks like, I think is good for a NICU therapist to remember. Like everything we do needs to look like what a full term healthy baby would have experienced both in the womb immediately after birth and going forward. And then I think it's really good for the outpatient therapist to really understand and appreciate, because they're so used to normal, they get normal, but kind of understand how that is taken away from these babies and what that means for their neurodevelopmental outcomes. So I think that would be a great start. And there's some great lectures, there's some great professionals. So for any of you that are listening and you do want to like dive into this, first I would check out the CNT website. They actually have a living bibliography that they add to, so you can go and look at some great resources there. I would also go on to Dr. Brown's Medical. They have these webinar series that are free, and you can really learn a wealth of information on there. I actually think I have two. They're retiring one soon because it was done like in 2012, like it's old. But I'm actually giving another one in June, all about transitioning flow rates and like
Ooh.
why and the criteria to transition flow rates and what we're looking for. So, but it's great. They're free. So you could delve in there. Catherine Shaker is great. The National Association of Neonatal Therapists, which we call NANT. It's a governing association, kind of like ASHA, but just specific to the babies. It's a beautiful community. It's like full of love and joy and passion and companionship and camaraderie on all of the big things and the little things. But if you become a member, they have a lot of education as well. So if you're passionate about the little ones, the little babies and their families, I would say those are some really great starting places to get that education.
And
I
we can
love,
link to all that
yeah,
Yeah.
we'll definitely
too.
link through all
And the
those.
article too. Were you there, Bree, when she mentioned about the Britt Patos article?
No, but we'll
We
link
have
that
to
as
we have
well.
to link that. Yeah.
Cool.
Another thing, as we were talking about advocacy, again, knowledge is power and someone has to start. So let's say this is something that you're really interested in, right? Really, like maybe you're an outpatient therapist and you want to start being more involved in the NICU. The evolution of getting neonatal therapists in NICUs is still in its infancy. We actually do these practice analyses every couple of years through the board who does the neonatal certifications, called the NTCB. And our last one took data from 2019 and 2020. That was published under Bobby Pineda in 2021. But we're actually like literally finalizing the manuscript for the data collected just a couple of years ago today. It's going to be finalized and we're going to submit by next Friday. So look forward to that. That's going to be really great. But showing that like every year, more and more hospitals are seeking neonatal care. The American Academy of Pediatrics put out a position statement on service delivery in the NICU. And this was the first time they've ever included neonatal therapists. And they've said that, you know, if it's a level 2 NICU, you should have a consultative service if you don't have somebody in house, and that it should be NICU specific professional. And then for a level 3, they go on to say how many neonatal therapists there should be. And they differentiate between OTPT in one bucket and then SLP in a separate bucket. So it's just a great way to say, hey, I have a level 2 community hospital not far away. Let me get this data and go and call their neonatologist and see if I can start providing the service for families. It's a beautiful place to work. It's exhausting and sometimes it's territorial. And that could be a whole nother conversation about how to start in a NICU and the right way to immerse yourself into their cultures. But it's a great field. It feeds my soul. And I think that's something that we all kind of talk about as feeding therapists when we're helping other people and other babies and their families bond over feeding. And I feel like it feeds my soul. It's food for life. It sustains.
Yeah, when people ask like, "Oh, how are you doing all this different stuff?" and it doesn't feel like work when you're doing things that you love.
Yeah.
Like this doesn't feel like work at all.
I
You
know.
know,
I'm
I
always
love
like
learning about this.
chase those areas that you love to do, because then it won't. It really won't. And that sounds like so corny, right? It's like do what you love and you'll never work a day. You're like, no, you like actually really do enjoy it and want to go and do that, quote unquote work, because it's so valuable.
Yeah. And we need the
Talk about
passion.
the NICU culture though, because I think it can be really intimidating and it can make it challenging to have some of that collaborative care, especially when you're a newer clinician and you're working with seasoned nurses and physicians, I know that navigating that can be really overwhelming.
Yeah, and that has evolved a lot as well. When I started in the NICU, I was alone and I felt the need to earn my worth and to educate and to show everybody what I knew and how I could help and make a splash kind of. And I will tell you that was the wrong thing to do. Best intentions, right? But I'm a stranger walking into someone's home. Picture it this way, right? You can't just go in there and start opening the cabinets and being like, oh, this should be in here and that should be in there. And like, think about how personal your home is, right? Now think about like the term like mama bear and oh my God, what's the other term that's just about a hen? Anyway, this is how NICU nurses feel about their babies. Like this bedside is their home where they care for this baby and they are so dedicated to making sure that everything goes just right. So like now here comes somebody new and starts tinkering and tappering and changing things and making different recommendations and it's so outside of their comfort zone. And what I will say is every NICU culture is so different. There are themes for sure, but each nurse, each neonatologist, each advanced practice provider, everybody there brings something so unique. And there's just no way to box it into a thing that you can just know and assume and make assumptions for. So my recommendation is if you're new and especially if you're young, well, not even that's maybe not be nice, but I was really young and I think that was actually like that was like a nick against me when I first started in the NICU. But whenever you go in as if you're now walking into somebody's home and you sit and you make polite conversation and you get to know each other and you get to see the environment and you get to learn about them before you start changing it all up, right? So I always recommend the first 2 weeks of a new job in the NICU, just go and hang out and get to know them and know their names and know their families and say, oh, this is so interesting that you're doing this. Can you teach me? Can you explain this to me? And learn the workflow and learn the comfort level. What it will tell them is you're invested, you're investing your time in learning about them and their lives, that you are dedicated to these babies because you want to understand all of the care that they are providing. It lets them know that you're a team member. And then as you start making recommendations, you are no longer this stranger in their home. You are now somebody that they're like, hey, how you doing? How was your weekend? And then you can be like, hey, you know what? I just kind of saw this and this is what I was thinking now that you're seeing patients. It's no longer that defensive. It's no longer territorial because you're already in. A lot of times we do it backwards, right? We come in too strong, too hard, and then we're like, oh God, that didn't go well. We gotta, and then it's like awkward because like then you have to like try to like sneak into the nurses lounge and sit and make small talk, but like there's already this like thing. So start being a person first.
That is
I
such
love
good
that. I like it's like
advice.
a comparison of like becoming like housemates, right? Or like roommates. It's like, okay, we come in slowly, we learn about each other and then build from there. I think that's a really, really great comparison. For
It's
And the
relationship
same true
building. You're
for,
on the team together. You've got to build a relationship if you want to be a strong team.
yeah, and it's true for how we work with caregivers too. Because if we come in hot and we're like, you need to do, it's overwhelming. We haven't built that trust. We haven't built that relationship. We haven't listened to know what's meaningful for them or what's going on. So I think that's such good advice across the board is listen, pause, listen.
build that relationship first. I think that even goes back to some of our early conversations about like why is it that parents go to social media for these answers, right? And it's not to say that the clinicians are not necessarily providing
No,
similar responses, similar answers, but on social media they maybe have spent time building that relationship first. They have built that trust. They have found this group or support system or whatever it is, and so they're seeking information there because like Tova said, it's like if we come in hot, they're like, well, I don't even really trust you yet. Versus like, let me spend time building this this up first.
Yeah. When I was doing outpatient and still in NICU also, but outpatient, I had a lot of student observers and student interns over the years. And one of them remarked, I wasn't even paying attention. It wasn't intentional, but she had said, she goes, you spend a lot of time getting to know the patients before you even start talking clinical. And I was like, oh yeah, like that's part of it. Like they come in and I'm like, hey, how are you? Oh, I love your jacket. Look how cute she is. Oh my gosh, is this your only child? And blah, blah, blah. We chit chat we become friends. And then I don't open up my computer. I have a notepad in front of me, but I say, okay, tell me everything. Tell me what you need. Tell me what's going on. What are your concerns? And I let them vent and unload all of it before I ask any other follow-up question. I mean, and I'll support them. And I'm like, oh my gosh, that's so hard. And I'll validate all of their feelings about what they're feeling. Because for them to schedule an appointment to a feeding specialist, that means they're already in the trenches. That means like 90% of them start crying as they're venting. Like I always have the box of tissues there. It is so, so hard for them. So giving them the floor to get it all out and validating all of their feelings is a great way to start the relationship with those families. And similarly, if you wanted to start doing more interprofessional practice amongst your colleagues that might be working, invite them to coffee and just chit chat first before you start jumping into all of the clinical questions. But coffee is like a great icebreaker. Let's go grab a cup of coffee. Come. Oh, you have a break? Me too. Come on, let's go get a cup of coffee. What'd you do last weekend? This is all part of trauma informed care, right? I don't know if you guys, it's like a big buzzword. There's a really great trauma informed professional certificate program by Caring Essentials with Mary Coughlin. She also has a really fun podcast called Caring Out Loud. But her certification program, it's amazing because it makes you look inside yourself and to work through your traumas so that you can be much more sensitive and aware of how you might be triggering other people and how NICU experiences or having a baby with feeding difficulties might be triggering, so that when someone has a response, instead of us being like, oh, they're a challenging family, or, oh, be careful, this one's a loud one, right? Like before we judge these families that are going through this horrible, horrible experience, it allows you to take a step back and show up with more compassion for them and that relationship. So
I love it because you're talking about the human side of healthcare and what Bree shared too. It's like sometimes the families are seeking out support elsewhere because we don't always go humanity facing. A lot of times it is what you described where we're looking at the chart and we're like, okay, X 25 weeker, CLD, and we're reading these labels, these diagnoses, and we're not necessarily thinking first about like, oh man, this mom's probably really tired, or like, oh gosh, she probably had 7 other appointments this week, or, so getting that human side first with our colleagues and with these families it makes all the difference.
yeah, yeah. I had a colleague who used to have like a tremendous intake packet, like a tremendous. And we were at lunch one day and she's like, I don't know what's wrong with these families. They're never filling out my packet. And then like, when I ask them for it, they're like, oh, what are they doing? And I'm like, are you out of your mind? Get rid of that packet right now. Like you make it nice and short and sweet. Like on our intake for families now on our multi-state private practice, our intake that they all get literally is like, what are your concerns? How do you like to learn? So that I know if I have to be extra, like it's all about them almost. Like I don't know. I think it just makes a huge difference. And then if you do have an intake form, if they don't fill it out, just remember to be compassionate to them. Because again, they may have had 7 other appointments that week. They have screaming babies. It's not easy. So also it's triggering. Writing down what's wrong sometimes can be a huge trigger. So we want to just be extra compassionate to that.
One thing I wanted to mention, kind of going back just a little bit, you had made a comment about, again, reiterating that like knowledge is power, right? And so even for clinicians that are in the home health setting or the outpatient setting, right? We're sitting here thinking like, I would love to support these infants and support this transition. How can I help? And Tova, you mentioned like there's lots of clinics, there's lots of home-based therapists, like where's the disconnect happening? And I think some of this also goes back to like, again, the passion that those neonatal therapists feel for their patients are like, I don't want to just send them to anyone. I don't want to say like, okay, go out and find a clinician on your own and I have no idea their training. I have no idea their level of support. And so really, I think for, any of you clinicians that are like me and you're home based or, you are outpatient private practice, you're seeing the transition, right? You're seeing them when they are discharged home. Remembering that like you also, this would be like a big advocacy, bigger picture is go to those clinicians that are in the NICU and say, hey, I just want to let you know, like, I'm trained in this. I have this, I am a provider who can support you, who can support this transition so that those families, again, don't end up like therapist to therapist to therapist because they go see someone and it sounds great in theory. And they're like, oh, whoa, like I've only done feeding for kids over 12 months old. Or, I've only really worked with toddlers, or like to get a X25 weaker, you're like, oh, there's a lot more information that I need to know, and a lot more training I need to know. And that also means that if you're even interested in this, just start seeking the training, start asking those questions, and start building those relationships with those neonatal therapists because they also will teach you a lot. Like I think about my Lori, shout out Lori. Lori Quinones is the NICU and inpatient SLP that I consult with a lot in our area, and she's fantastic and has taught me so much to help with that transition. It's not, we don't even have quite that like formal, like, oh, from here to this follow-up. And it would be, lovely to have something like that come into play. But for now, it's like, hey, just building that relationship has been super, super helpful to know, okay. And then it expands. It expands from there because now I can help mentor another clinician and then they can help mentor another clinician. And then you expand it by giving back to those other clinicians that are seeking to learn more too.
And I think mentorship is like a key theme. Like you need to not just learn from textbooks, and you need that one-on-one, like that the foot on the ground is so important. So I love that. Yeah, reach out to them. I do a lot of lectures in different NICUs and all of them like, we have nobody. I'm like, but have you looked? They're like, well, no. I'm like, well, how do you know? Like, so they don't know you exist. If you really want to start helping these kids, reach out to them, let them know you exist. It's
And
good.
most people want to help. Most people want to be helpful in this field.
Yeah.
And yeah, and even the hospital where I do my swallow imaging, they have a NICU discharge coordinator. And I think sometimes, when it comes to some of the admin stuff, it's a lot. We already have a lot at our jobs to do, but if we can just touch base with her and say like, hey, I think if we refer them to these two places, I think that would be a good match for the family or whatever. And there's usually people at hospitals that can help with some of that coordination piece.
Yeah. A lot of hospitals have like a discharge folder with like certain recommendations. Like ask them for a flyer, and that if we could put all of these flyers in, right, so that they know it's there. They don't have to go Google searching and wondering. It's a great. They do this for lactation consultants, so I think doing it for neonatal therapists is a great option as well.
Yeah. And something you mentioned, Bree, about like when a clinician might feel like I'm comfortable if they're over 12 months or if they're a toddler or transitioning into solids. Um, being aware of where your skill set is and when you need to get support. And I can think of a specific person who had reached out to me on social media last year. And she had asked, I got this case and it was very medically involved child, and she didn't have any experience with feeding and she didn't have any support at her job. And she asked, like, so what should I do? Like, what should I do at the first visit? And I said, I think that the best thing that you can do is to say that you need to give the case to someone else. And then you go, if you're able to go with that person, you go with them while you're seeking out more learning. And she ended up taking your course, Bree. And now she reached out recently and she's doing a lot more with feeding and swallowing, and she's continuing to learn. I don't know if you know who I'm talking about, but I
I
think
remember this conversation. Yeah.
yeah, but but that is the best thing that you can do for that family, is to recognize that you might not be the best fit right now. And it doesn't mean that you'll never get to work with that population. It just means you have to be proactive. Like you shared, Dr. Lisa, you have to be proactive and seek out mentorship, seek out support, seek out more learning, and you'll get there. And people are happy to have a lot of people are happy to have observers. But that's and I made that mistake as a newer clinician where I'm like, this is the only way I'm going to learn. I can't give up this case. I have to go and learn. And I got booted off some cases because I was out of my depth. I was out of my depth, and it wasn't fair to the family. They're not our school. It's, they deserve to have quality care.
No, I love that.
And
There's a difference of like scope of practice and like what my scope is, right? Like I'm,
ethics.
yes, that goes into the ethical side.
This is a critical winter for these kids. How
Yeah.
they learn how to suck and swallow is the foundation for later babbling and for later feeding skills and later speech development, and like it's tremendous. I had a mentor who literally said, you got to fake it till you make it. Take the case, figure it out, ask your questions to other professionals, and do it. And like there were a couple years there, I'm like, I'm gonna fake it till I make it. And it wasn't the right thing to do because I did not serve those families the way that they deserved to have been served. And so, yeah, I love this
Yeah.
message.
Mentorship is huge. And like, I think like you said, Louisa, it's like, have you even looked? Because I want to like tell people like, just because someone's not on social media shouting from the rooftops what they do, and like guilty, I'm on social media, I know, that doesn't mean that they're not in your area and available and knowledgeable and skilled to provide that mentorship. So like just look and see if there's somebody that would be willing to, even if it is just, hey, can we get coffee like once a quarter so I could just start to develop a relationship with you? There's a lot of people that want to help. We really there really is.
I mean, you probably know because you guys are doing this podcast, but like we love talking about this stuff. Like someone calls me and I'm like, yeah, let's hop on a call and I'll tell you everything you need. Like we love it. We're passionate about helping anytime we can. So reach out. Like I think we're easy to approach.
Yeah, I appreciate that.
I don't know. I would be intimidated to reach out to you, Dr. Louisa.
No, I get so many emails for like,
Really?
yeah,
I
I'm
mean, it's incredible. No, but because when you called me, I forget how long ago it was. I was like, oh my gosh, Dr. Louise, that's calling. Yeah, but that's amazing for people to know. Like we all just want to help.
Yes. And again,
Okay.
there's great resources around. So anyway,
Yes.
I'm sorry, Bree, what were you going to say?
No, I was gonna say, I feel like we're at a good transition now to kind of touch base on some of your current research projects, dive into those a little bit more and kind of what's like planned moving ahead. I want to hear what you're doing.
Okay. So research is a huge love of mine. Interestingly, when I started the PhD program, it was because I love to teach and I love to educate, and I thought that would be great. I had no idea I was going to fall in love with research. It is so amazing. Like think about the feeling where like, when you help a family and you leave there, you're like, oh my God, like I helped them and it felt so good. When you publish research, you feel like that times like 600,000. Like my first publication, I got an email from Greece. I got an email from Germany thanking me for my work. Like it's the best feeling because not only are you now helping the babies you touch, but you're helping all of the babies that all of the people who read your publication touch. And so the impact is just a beautiful way to give back for the time and the little bit of exhaustion that happens when you do research. But it's a beautiful way to spend your energy. So my current research agendas are a few. One of them is we are investigating the use of cold milk in neonatal dysphagia. As you all know, right now we rely pretty heavily on thickening. And while thickening isn't our first trial in a swallow study, right? We're trying flow rate and positioning and pacing, and a lot of these kids end up on thickening, and I'm grateful. This has saved so many kids from G tubes, and so it's a beautiful modification that we have, and we shouldn't take it for granted. However, it does lend itself to a lot of difficulties, a lot of variability, a lot of different recipes, and like so much matters. There are so many variables that you cannot control for. For example, are you using rice? Are you using oatmeal? Are you using quinoa? Because all of these have different grit sizes. Are they all going to flow through the nipples? The nipples, what flow rate do you use? Is it a nipple hole? Are there many nipple holes? Like, how does that work? And then are you shaking? Are you stirring? Are you using an emulsifier? Because that will all affect it. The temperature, the caloric density, the time in between feedings. batches. Like there's huge variation between different formula batches, different breast milk batches, different thickening agent batches. So it is just wrought with inconsistencies that will negatively affect babies. If it's already hard for them to clear what they've aspirated for thin liquid, think about how much more difficult it's going to be for them to clear a thicker liquid. So it really is important that we figure out easy, good workflow and effective ways to help these babies. So with all of these problems with thickening, I literally, you could open any like NICU resource book and they say cold liquid. I was like, no kidding, cold liquid, but there was no research on it at all. So we were the first research group at NYU Langone on Long Island to look at cold liquid in preterm and full term babies. And yeah, aspiration and penetration both decreased significantly, but it was a pilot study. So it was only the first 5 swallows. We kind of had to do that from IRB standpoint because they didn't want us to radiate babies unless we've proven it to be somewhat effective. So once we got that pilot, we then expanded the study to look at cold feedings under a bunch of different condition. So we did it at bedside to investigate if it affects coordination of suck, swallow, and breathe using the infant-driven feeding scale. So babies were rated, a 1, 2, 3, 4, or 5 based on their coordination. And then we took those, averaged them, and then we did find that the babies on the cold feeding had better quality scores. They had better coordination. We looked at safety. We were doing body temperature, axillary temperatures, and also gastric content temperatures. So we found that by the time the infant sucks this really small bolus, just it passing through the mouth and esophagus into the stomach, it already goes to body temperature. So there's no concern of like a cold stimulus in your stomach. Like if I drink cold water, my whole body just turns cold, but we're taking giant gulps. So the size of the bolus and then that transport through warms really, really quickly. Doesn't increase any residuals, no more vomiting, no signs of intolerance, no increase in A's, B's, or D's. So we've kind of established that it's safe. And we also then started doing full feedings under video fluoroscopy or fibroscopic feeds. And we're in the middle of data collection right now. We're done with enrolling participants, but the data is really powerful that it does actually improve neonatal dysphagia and reduces aspiration and penetration. So it's another tool in our toolkit. When you have a kid and maybe they're not responding well to the thickening, we can maybe try the thicker liquid that is cold. We can use ITSE testing or line spread testing to make sure that it's the appropriate mildly, slightly, moderately thick. But cold should definitely be something on your radar to use.
That is really cool. I'm excited to read that.
That is
I'm
so
curious,
cool.
when you do a full feed you mentioned under video fluoroscopy, you're turning fluoro off, right? Okay.
Yeah. There's time segments. So we'll do like a window in the beginning and then 15 minutes or whenever they start showing signs of tiredness or fatigue. And then we'll do another like 20 swallows. So,
Oh, okay.
so
Yeah,
I
that's
love
interesting
that.
because I usually do like 5 swallows and then we turn off for about 30 seconds, 5 swallows.
yeah.
So,
So that was like the first part. So we were obviously only enrolling children that were infants that had dysphagia. So it was during their first swallow study. And so the clinical SLP would do a protocol like that, similar to like what Caitlin McGrattan had published with like how to
mhm,
do like a really standardized. And
mhm.
also baby IMP and BSM IMP is out now. So that might also be a great way to standardize it because you want to do fatigue testing where you know that their swallow changes significantly, especially after the first 90 seconds. So doing those fatigue testing. So she did all of that. And then if it was established that the baby had dysphagia, the baby then did their trials to figure out what's going to be best at bedside because we didn't want to interrupt the clinical care for research. So she did all of that. And at the end, we then trialed, I think it was 10 swallows cold and then until the baby fatigued and then another 20 swallows at the end.
I see. So it's for babies that you already know they have dysphagia. You already know what interventions you've tried.
Yeah.
You
Yeah.
try at the beginning and then you wait and try at the end. Okay, that's cool.
I love
Yeah.
how functional that is. Like from so many different standpoints, like you were mentioning all the different challenges faced with thickening liquids, right? Like this is something that's like very easy to implement into an instrumental, like into the protocol you're already doing to say,
refrigerator cold. Take it out of the refrigerator and
like,
feed it to the baby.
yes. And, you know, for families, if that is something that would work, oh my gosh, I mean, I have my baby with me today. Don't tell him that cold, you know, is a good thing because he doesn't want to hear about it. But I'm like, maybe if we had just done that from the beginning, straight from the fridge. But anyway, I just love the functionality of that because it's something that can be very easy for clinicians and families to just like implement into practice very.
Lisa Newman wrote an article in 2001, which found the two findings that I love the most from her article is that one, penetration is a significant red flag for later aspiration. So if you are doing a swallow study and you see babies having consistent penetration, don't wait for their aspiration. We know it's going to come. So what we find is that some kids are super sensitive to the aspiration, and once they aspirate once, the likelihood for them to aspirate more increases. So think about it. You're out with friends and family and you're having dinner and all of a sudden food goes down the wrong tube. You spend the next 20 minutes going, right? They don't have a throat clearing reflex, so they can't do that. And then has it ever happened to you like 10 minutes after you did that, it happens again? Because now there's so much irritation there, you're like compensating, you're trying to change it, and now you're increasing the likelihood for more aspiration. So Lisa Newman found that repeated penetration events always resulted in an aspiration event. So you do not need to wait for the aspiration. And then just make sure that you're really clear in your report about why you stopped. Because if you're doing like a PIS scale, or, you know, some doctors like, oh, well, you didn't even have aspiration. Like, they need to know that penetration at a certain degree will lead to that. And then the second finding was that if there was going to be an aspiration event, almost all of them happened after 90 seconds. So that's where we got that.
Introduces that fatigue piece.
Correct. So
that's really good to know. There was a recent study too about the frequency and depth of penetration, placing babies.
That wasn't that Caitlin McGrattan?
I think it was.
Yeah. I love her data.
Awesome.
She's amazing. Yes.
We really have so many impressive clinical researchers. We're very lucky. And, you know, considering that like 80 years ago, NICU babies were in circus sideshows. Like, there were no NICUs 80 years ago. Like, the whole idea of neonatal care is in its infancy. We're learning so much so fast. It's evolving like at speed of light. Things that I did 10 years ago, I'm not doing now. I'm changing it all based off of this literature. So I think one of the most important things maybe for clinicians is to remember is be ready to flex, be ready to pivot, be ready to be flexible, because we don't know what we don't know until we know it. And it's important that you don't hold onto your beliefs too strongly. But we want you to think outside of the box, and we want you to practice evidence-based practice. But at the same time, we want to use that evidence to do good.
I know Brie loves when you say that.
I do.
We're always learning and we don't know what we don't know.
I always say, like, a lack of evidence doesn't mean we just fill in the blank with whatever we want.
Yeah.
We just still have to use that strong foundation of research to then guide us to be more curious and ask more questions and, you know, open up new possibilities. But we can't just put whatever we want in there.
No, but if it's innovative, if it's you got sometimes to try, right? So I feel like the new paradigms for family-centered care is something that we're really actually not ready for as clinicians, because we fall into this, I'm the professional and I'm going to give you what I think you should do. And I think we really have to remember that it's a recommendation and we are responsible for this whole knowledge is power. When we talk to a family, or if you're working in a NICU and you have a protocol, you have a standard of care, you have a protocol, this is what we do, right? This is evidence-based, this is what we do. You have to remember that that's not your job, which is hard. It's really hard for us. You have to remember that your job is to say, mom and dad, caregivers, this is best practice. This is the protocol that we made based off of the evidence. This is the reasons why we do this, but there are other options, and I'm happy to share those with you. Would you like to learn more, or would you like to look at this protocol? I know we face this problem all the time with feeding babies on high respiratory supports and high flow rate. Like some NICUs still do it, some practices don't, some PICUs do it. Like, but it's our job not to say, oh no, you can't do that, or oh no, it's fine. It's okay, mom. There's this one study that shows that when you feed a baby on high respiratory supports, they aspirate more. But there are other studies that show that their outcomes are okay. Let me explain to you why it's a concern for me, and then tell me how that makes you feel. And if you decide you want to feed your baby on CPAP or on 5 liters of flow, that's your decision. Even though we don't do that, even though we don't recommend it, even though that's not best practice, this is your choice. And we have to kind of let them understand. I think sometimes we're worried about overwhelming families, like, oh, we don't want to, like, oh, there's too much information. No, knowledge is power. They need to know how to advocate for their babies. They need to know what the best plan is. I'm not saying you have to go and throw every medical term at them. You could dumb it down and bring it to more like that 8th grade level, which is where we like try to speak without all of the jargon. But they need to know that there are more options for them. So if we're really going to be family-centered practice, our goal is to approach these topics with giving them all of the sides, giving them all of it, and then letting them come up with a decision. And let's say the decision is not what you would normally do. Let's say that decision doesn't maybe align with you or your NICU or your culture or your practice, but it works. Then you need to write a case study, and you have to let the rest of the world know, because how else are we going to know about this? Right? So this whole idea of case studies and writing and like, just put it out there. Make it a actual leader article. I don't care what you do, just write it up, because we need to be innovative. We're in the infancy of neonatal care. We need smart people trying bold moves with the parents' consent and with the parent, but we don't know until we know. So big
I
advocacy
loved
for
your
that.
talk a couple years ago on CPAP with Kim Morris when you guys did that talk at the
Oh, the
Ashley
debate, that was
conference.
so hard.
I can imagine that was really hard. It was really good. And the thing about it, oh my God, you're disappearing. No, the thing about it is that this stuff that we're doing is not black and white. And so even when we think about like being an authority and telling parents what to do or like giving them options, sometimes I truly don't know, and even when we're talking about this conversation with frequent penetration, like I did a swallow study last week on a baby who after the first 5 swallows, she penetrated almost every swallow. She's probably aspirating at some point during feeds, right? Does that mean that we limit her and drop a feeding tube while we try to figure this out? Like what it's not black and white. And that's part of what makes our job, part of what I love about the job, part of what's really stressful about it, is that we're taking this evidence that we have, we're taking our clinical experience, and we're just giving options and doing the best we can sometimes.
That's it. And that's all you will ever be able to do in life. Just do the best. And you're going to be wrong sometimes. You're going to make mistakes because you're human. And this is the way it goes. But try your best. Learn what you can learn. Get the mentorship you seek. Show up for families, right? I think all of these things are kind of what make us so good at what we do. Like, I don't know, but like, I feel like our group of pediatric feeding therapists, like we're good people. Like we really show up. So yeah, for sure.
Thank you so much for showing up.
No, thank you so, so much. This was just, oh my gosh. I feel like I could sit and talk to you for like another 5 hours.
I agree. You girls are great. You guys are like, this is so good. I think people just need more of these conversations. So I'm so proud of you guys for like starting this podcast and getting it out there and
Free.
social media and all of that. I mean, just you're killing it, and it's needed. It's necessary. So I hope you guys feel really good about all of your efforts.
Thank you. Yeah, we felt like there was a need for some of these more like nuanced conversations, difficult information. Like you said, knowledge is power, and I really believe that like we can find ways to push that out there, get people to question what they're doing, become more curious about other avenues of, research and practice, and hear people have the nuanced conversations that I think so many of us are having. it allows us to be more accepting of changing our minds and changing our practices and developing, best practice, family-centered care, supporting all of those areas. So we thank you for being part of our mission to do so.
Well, I'm always happy to come and talk anytime you guys have a topic. This was really great. And so keep up the good work. And I'm always happy to chime in and be a resource for you all.
Awesome. Thank you so much.
Welcome.